to go over the principles of pharmacodynamics in the medication response. So pharmacodynamics is the mechanism by which medications produce a biochemical or a physiological change. So basically, what the drug does to us, any alteration of function within the body. Now, any medication can potentially cause toxic effects, but most of them can be fairly safe when given correctly. In order to understand pharmacodynamics, you need to understand mechanism of actions for the medications, because that's all this is. So when we're looking at medication administration, the medications are going to act in one of four different ways. They're going to bind to a receptor site, they're going to change the physical properties of the cell, they're going to combine with other chemicals within the cell, or they're going to alter a normal metabolic pathway. Most of these medications are going to operate by binding to a receptor site. Right? Almost all medication receptors are going to be on the protein molecules of the surface of the cell. And these receptors are usually named for the type of medication that stimulates them. So, for instance, if it's stimulated by opiates, it's going to be an opioid receptor. Now, a couple terms here. The force of attraction between a medication and its receptor is called its affinity. So some medications may have a stronger affinity for the receptor sites than others and can actually kind of boot them off of wherever they are going. Okay? A medication's ability to cause the expected response is called its efficacy. So basically, how efficient is it? How good is it at producing its desired effect? Some medications may work really well, but they're not very effective, so they aren't reliable. It can't always cause that expected result. Okay, now, one important thing to note about medications, some of the newer medications, as they come out, they're always striving to improve them. A lot of older medications may affect a lot of your receptor sites, which can cause some pretty nasty side effects. Some of the newer medications are designed to actually target only specific receptor sites, which helps a lot. When we are looking at your receptor site, they're going to fall broadly into two categories, agonist and antagonist. An agonist is going to bind to a receptor site, and this is going to cause it to initiate an expected response. So basically, it's going to make something happen, what you would expect to happen if the body's natural chemical were to bind to that receptor site. Now the medication is going to cause that action. Your other is going to be an antagonist. And so an antagonist is going to bind or block a receptor site, and these do not allow the receptor to initiate the expected response. So you have a blockage, basically. Now you also have partial agonist or agonist-antagonist, and basically these block, they plug in and they initiate some response, but they block others. For instance, Nubain is an opiate agonist-antagonist. It gives some of the pain relief expected with opiates, but it doesn't cause the respiratory depression that's often associated with your opiates. Another important side note of your antagonist, you have two different major types of antagonist. You have your competitive and your non-competitive antagonist. So your competitive are going to temporarily bind with the receptor sites, and the efficacy is related directly to the concentration near the receptor sites. For your non-competitive antagonist, these are going to permanently bind to receptor sites, and they're going to prevent activation by agonist chemicals, and this effect is going to continue until new receptor sites or cells are created. So these are not going to be overcome by agonist chemicals or anything of that nature. Now, your alternative mechanisms of drug action, these are not as common as the receptor sites, but they do happen. So your medications that are going to act by your physical properties, this would be like changing the osmotic diuretic, or the osmotic diuretic that increases the osmotic pool of the blood. So this may reduce the water reabsorption in the renal tubules. That would be like your Lasix, okay, which is going to increase your urinary output and reduce the water content of the body. Medications can participate in a chemical reaction that changes the chemical nature of their substance. So, for instance, isopropyl alcohol that we use this as a disinfectant, it denatures the proteins on the surface of the bacterial cells, and this ruptures the cell, destroys bacteria. That's why we have to let it sit there, because it takes a little while for it to happen. Antacids are another one. They actually neutralize the hydrochloric acid in the stomach. And then the last one is going to be altering your normal metabolic pathways. So this one might be like an anti-cancer drug that mimics the normal parts of the cancer cell metabolism, and it's going to prevent or make it inactive where it doesn't reproduce anymore. Now, there's quite a few things that actually affect your response to medication, and based on these effects or what we know to expect might change your choice of medication or the dose that you give. For instance, if it's a very hepatotoxic medication, you may give a lower dose or choose a whole other medication if somebody has liver cancer or something like that. You may change the route or the timing of the medication or the manner of administration based on your assessment. So some things that you want to consider when deciding medications: the age. You may want to consider titration of a medication for pediatrics or an elderly patient. They have altered metabolism and eliminations, and so they can have more toxic effects very rapidly. Weight-based medications, advantages is that it's proportional to the size of the patient, and most of the manufacturers have already calculated in these factors when they are deciding on the dosages. And you can use an appropriate dose for all ages. The limitations: you have to be able to calculate their weight in kilograms. It does not consider any changes in distribution, metabolism, or elimination, say kidney failure, liver failure, something like that. And it's largely based on their ideal body weight. So if you have somebody who is morbidly obese, you might potentially give them too much medication even though it is still based on their current weight. Most of the dosages are going to be based off of ideal weight. The environment, if they're hypothermic or hyperthermic, if they're too hot, it may increase the metabolism of drugs, so it may not work as well. If they're too cold, then you're not going to have the circulation needed to move the medications through the body. Some genetic factors, if you have primary pulmonary hypertension, with them, if you give them vasopressor medications, they can have a real acute decompensation really fast that you're not expecting. If you have somebody who has sickle cell disease, diuretics can cause them really bad complications. If you have this glucose 6-phosphate dehydrogenase deficiency, never met a patient who did, but if you did, if you give them a sacilitate, then it can actually precipitate hemolysis, which is bad. So we want to make sure that we're looking for these other information. And I feel pretty confident if you have somebody with one of these problems, they're going to tell you. You'll be able to figure it out during that history, assuming they can answer any questions. Some other things: pregnancy. Not only does it increase the cardiac output, the volume, the respiratory tidal volume, renal blood flow, and all that fun stuff, you've got, increased motility, GI tract, you've got decreased hematocrit. So you've got a lot of changes in the body that will change the metabolism and the pharmacokinetics of the medication, but also you've got to consider the effects of the medication on the fetus. Is it safe for the fetus or not? Psychosocial factors, pain, anxiety. Some medications may have a placebo effect, so that can, you don't know sometimes, is it really doing what it's supposed to do? People think if you give them medication, you tell them it's supposed to help. They may interpret it that it's helping, or that it's not helping if they're convinced that it's not going to work. Some other terminology here: therapeutic effects. These are what we want to happen. So we need to make sure that the medication we pick is based on their illness, injury, complaint, whatever is going on, their signs and symptoms, and that we are giving it in a dose that's intended to produce a desired clinical response. Okay. Now, your therapeutic index, this is where you have basically the median effective dose. So it's somewhere between the lethal dose and the toxic dose. We want to make sure that we aren't at the lethal dose or toxicity levels, but we are giving enough medication to cause that therapeutic effect, that desired effect. And the therapeutic index is just the relationship between the effective dose and the lethal dose. So if it's a very big difference, then that medication is generally considered to be safe. But if it's a very small window there, then that patient needs more careful and monitoring to make sure that they don't become toxic or have any lethal side effects from it.